Thank you for your kind introduction. And here we are one more time, because this morning you had a wonderful lecture about urinary tract infection. But clearly this is a real challenge. This is our everyday challenge to educate, to treat properly our patients with urinary tract infections. And despite major progress in the treatment of our patients, intermittent catheterization was the first one. Also, new drugs to treat neurogenic detrusor overactivity. It's still a major issue. And when you look at, for example, this publication, which is a very recent one, 2 years ago, from the SCI database in the US, only expert centers, patients followed at 1 year. As you can see, that for all patient urinary tract infection is still the first complication at 1 year. Second point, it's not only spinal cord injured patients. And it's a very interesting study because when you look at the emergency department utilization in the US, and when you have all the data for all those patients going to emergency unit who do have neurogenic bladder, you may see here that, yes, quadriplegia, paraplegia, they do have urinary tract infection, but MS also, we know that, and Parkinson's disease patient. And in fact, the most important group of patients is Parkinson's disease. So probably here we are more aware about spinal cord injury, all those algorithms of treatment that we use for our patients. And we know that intermittent catheterization is the gold standard for those patients. But we have to reconsider the fact that in other group of patients, multiple sclerosis, for some of them, for Parkinson's disease or Parkinson-like population of patients, urinary tract infection is also an issue. And the last one, probably one of the most interesting things, when we have to fight also on trying to convince the neurologist in charge of our patients, and especially the MS patients. And I would like to thank Jalesh Paniker and Bernie Porter for this slide, because probably it's one of the most interesting slides about MS population, unplanned admission for MS patients. You see here that urinary tract infection, top one, from far away for all the other symptoms they may have during the course of the disease. So the challenge is not only for SCI, and it's probably also very, very important for MS patients. And you see here that indwelling catheters, it's a nightmare for urinary tract infections. Probably the first rule is to avoid indwelling catheters in this population of patients. And for all patients who are coming from the orthopedic department to rehabilitation department, the first thing to do is, do we really need of indwelling catheter? It's an everyday problem. We have to reassess, yes or no, we still need the indwelling catheter. Usually it's no. Clearly there is rules regarding urinary tract infections. And those rules are very simple. This is why you are so important in terms of education. Just for the patient to understand that all those rules are important one by one. If there is a discussion about urinary tract infection, always do full clinical examination. Fecal infection, skin disorders, pressure ulcers, all those conditions can induce incontinence, increase in spasticity, and so on and so. So always do full clinical examination. No self-prescription of antibiotics. It's a nightmare, because in this case, the risk of increasing the multi-drug gem resistance is very high. No antibiotics in case of cloudy urine. Please simply ask to the patient what they do with cloudy urine. Nothing except increasing the fluid. If it still remains, yes, we can discuss, but nothing more. In case of fever, ultrasound or CT scan, because, for example, if there is a ureteral obstruction with fever, depending on the level and the completeness of the lesion, the patient will not suffer from pain. So you have the risk to not making the diagnostic of ureteral obstruction. So in case of fever, you have to do more than urine culture. Always urine culture before antibiotics, but it's always a Sunday problem. And every patient said to me, or to the nurse in charge of education, yes, but it's always a Sunday that I have my urinary tract infections. I said, who cares? You have your urine, you put the urine into the fridge, and when you are coming back the Monday morning at the lab, you say, yes, it's my urine from this morning. Because the only thing that we want is the culture of the germs. We don't care about leukocytes. We want to have the appropriate antibiotic sensibility. That's the only thing we want. So please don't have any antibiotics without urine culture. And it's feasible even in Sunday. And no urine culture to check urine after antibiotic treatments, it's a nightmare because it's a never-ending story. You check, 2 days after there is another germ, so the patient have, yes, I have a urinary tract infection, have to be retreated, my antibiotics doesn't work. Yes, but who cares? If you don't have any symptoms because of the antibiotic treatment, and if antibiotic prescription was based on urine culture, you don't need anything more. And no urine culture for urine bags. This is very important. Please follow the rules of intermittent catheterization. Every patient is different. They want to have their own rules. Yes, it doesn't mean that there is no rules. There is rules that we may adapt, but there is rules. No over-distension, a good diuresis, and a frequency high enough to avoid the risk of having germ for a long term within the bladder, plus over-distension. So it's 5 times a day, volume less than 500, and the diuresis about 1.5 liter. You have to choose the values, but try to make it simple, because if the patient is well educated, he knows very well to do the micturition diary. Just to adapt regarding the diuresis, it's Saturday night, I want to have fever. Yes, but you have to learn how your body goes with the beer. So if you want to learn, you have to do micturition diaries. Treat constipation. We discussed that this morning. It's a very important topic because you know that with the peristeen system, it was proven that you may reduce by 50% the risk of urinary tract infection. Why? It's a very interesting question. You know that there is a microbiota within the gut. Also, there is a microbiota between the bladder. And there is a discussion between the urothelial cells and the microbiota. The microbiota can be anti-inflammatory, can be pro-inflammatory, depending on the type of microbiota you have. So having a good control of constipation and decreasing the risk of urinary tract infection is probably related to those microbiota things, which are very complex, but clearly it's very important. And probably the last point before going to the clinical case is what you have to do in case of recurrent urinary tract infections. Please don't wait until the next annual visit. It's too late. We have to do things for you. If you have recurrent urinary tract infections, it means usually that there is a risk factors which reappears. It can be neurogenic decrease of activity, failure for treatments, severe constipation, or another thing. But we have to recheck to be sure that we are in a good shape regarding the control of the risk. It means having a voiding diary, urologic and urodynamic evaluation to eliminate all those precipitating factors. It's a short list. You saw the long list this morning, but there is a lot of things that you may adapt for our patient to reduce the risk of urinary tract infections. So you see here that it's a very complex problem, and there is a lot of issues that we have to discuss. So in France, Canada, and Belgium and Switzerland, we do have a French-speaking group of neurourology, and we worked with infectious disease specialists, and we did that, which is a support for the discussion with your patients about urinary tract infections. Urinary tract infections, this type of paper we give at every visit to the patient. We send it to the GP, and we try to explain to all the caregivers and the family what you have to do and not to do about urinary tract infections. So you may see here that it's all the things that we already discussed. So you have those papers at the entrance of the room if you want to use it or to translate it into your language. So it's first part, generalities. What is urinary tract infection and what is not? The fact that 50% of the germs are multi-resistant to antibiotics, what to do and not to do. No urinary culture control, no decreased catheterization frequency, no minute antibiotic treatment. Don't use quinolones, please, because it increases strongly the risk of multi-drug germ resistance. And some tips and tricks about antibiotics regarding, for example, Enterococcus or Pseudomonas aeruginosa, which always need a double antibiotherapy. And on the other side, if you have recurrent urinary tract infections, what to do at least? Micturition diary, ultrasound, urodynamics, and cystoscopy. Don't use antibiotics every day, always the same antibiotics, even if it's with low dose, because it increases the resistance of the germs. And there is solution, increased frequency, diuresis, prevention of overdistension, treating detrusor overactivity, treat constipation, respect good practice. Antibiotics can be discussed by specialists, and if you need to be treated, even if there is no risk factors, please go back to the specialist to discuss the alternatives to be treated as a preventive treatment. So I think that's all.